Good morning, everybody. So I have to confess, I did not go for a run this morning. I was more concerned about preparing for this presentation. So first of all, let me just thank the organizers for having me here. It's such an honor to be presenting to all of you, and I hope this initial framing will be useful going forward to help set the stage for the day. My presentation is too long, so I'm going to just launch into it so that we don't go over time, because I'm really looking forward to the Q&A discussion afterwards. So here goes, and the clicker. So whenever I give a presentation on the social determinants of health, I like to start with this slide, and I'm sure this pie chart is very familiar to most of you in the room, but for those of you for whom this is not familiar, this is a breakdown of the contributors to premature death. And a lot of these will be familiar to you. Environmental exposure, that's toxins in your environment, substandard housing, et cetera. Behavioral patterns, smoking, poor eating behavior, teen pregnancy, et cetera. Genetic predisposition, that's pretty straightforward. And your social circumstances. Do you grow up in poverty? Do you live in a neighborhood of concentrated poverty? Do you have access to educational opportunities and other upward advancement opportunities? And then finally, of course, inadequate access to healthcare insurance. And of course, what's interesting about this, which you all certainly recognize, is how small, relative to the other contributors, inadequate access to healthcare is in terms of predicting your likelihood of dying prematurely. And I start with this slide in this presentation because I want to make the larger point that our private sector solution to health thus far has almost exclusively focused on that 10% slice. And what I think we would all like to see happen, and I think this roundtable is a great start, is to expand the private sector role outside of that 10% slice and into things that affect your environment, things that affect your behaviors and your social circumstances. So that's what I'm going to speak to today. How can we leverage some private sector tools and strategies to expand the role of that sector out of healthcare exclusively and into something that's probably more accurately described as a market that values health, not just healthcare. So this is the world that we have built for ourselves, unfortunately, when it comes to health. This is a steep hill with a curvy road and a car that drives too fast and drives off the road and falls to the valley floor and explodes, requiring a hospital to be built at the bottom of the hill. So if we're going to get the private sector involved in the social determinants, we need to find a way to get them to invest not just in hospitals at the bottom of the hill, but in things that will keep people from driving off the road in the first place. Straightening the road, speed bumps, better signage. Because the reality is that a lot of the things that happen in the community, in the home, in the neighborhood, things like maternal health, things like maternal education, things like education for teenagers so that they don't become pregnant, things that would address poverty at a fundamental level. All of those things would keep us from having to build these hospitals, which are incredibly expensive to maintain. Why don't we do this? So the point that I really want to emphasize is that while we understand at a global level that affecting the social determinants of health through community interventions reduces the likelihood of downstream health care, there are risks involved. Sometimes those interventions, that prevention, doesn't work. It doesn't keep people out of the hospital. And when that happens, the people who otherwise have to maintain these hospitals have now double paid. They've paid for prevention that failed, and they're still responsible for paying for remediation because those people still require health care because that prevention was unsuccessful. So I believe the key to getting the private sector involved is to find ways to address and mitigate those risks so that their business benefits from making the appropriate interventions upstream that keep them from having to invest in expensive remediation downstream. So I've bucketed 3 general strategies for the private sector to invest in the social determinants. This is not an exhaustive list. Ray mentioned a number of different ways that the private sector can get involved in the social determinants that may not fall into these buckets neatly. But I think this covers the vast majority of potential strategies for the private sector to get involved. The first is corporate philanthropy that leverages the existing business of the corporation. So not just grants, but grants that actually support the long-term goals of and profitability of that business. Social entrepreneurship, social health entrepreneurship. These are businesses that make money by helping people. So the product that they create benefits low-income people or people in need within the context of health, products that improve people's long-term health and keep them from needing health care down the road. And then finally, pay-for-success contracting, which is the subject of my health affairs article that I published in November. I'm going to spend the bulk of my time talking about pay-for-success because I think that's the most novel of the 3 and maybe newest to all of you. But I'm going to very quickly go over the first 2 just to flesh them out a little bit more. So these are strategies to leverage corporate giving. This is a framework that was established by Michael Porter at the Harvard Business School. So he has identified 3 areas where corporations can make corporate grants that actually affect their bottom line in a positive way. The first is factor conditions. These are investments in common infrastructure that will enable business growth for all the participants in that marketplace. You can imagine, for example, Blue Cross Blue Shield has a community, I have it written down here, community health management system that they are developing that will map all of the assets of the communities in which their policyholders live. You can imagine them taking that infrastructure and making it open source, for example, so that everybody that operates in those communities can plug information into that open source infrastructure and they can share it commonly. That would be a way for Blue Cross Blue Shield to support their bottom line while also supporting the bottom line of the health industry as a whole. Demand conditions, these are expanding products into markets to bring more customers to your business. I can imagine drug companies, for example, giving daily antiretroviral drugs to giving away daily antiretroviral drugs to people of high risk of contracting HIV, for example. By giving those drugs away, you increase the chance of getting a critical mass of people using the drugs so that the common perception of the efficacy of those drugs changes and you have many more people clamoring to get a hold of the drugs and actually paying for them. So it's a way to use your corporate philanthropy to expand demand for your product in the long run. And then finally, context for strategy and rivalry. This is to effectively ensure some common set of rules for competitiveness among the people in the marketplace. You can imagine establishing some set of common health impact metrics that every hospital system and health provider in the country is held accountable to so that we have some ability to track patients as they move from provider to provider and how well those providers are keeping people healthy. That would be a way to, again, leverage corporate philanthropy to make the industry, the marketplace, more robust. So many of you probably have heard of the impact investing field. This is a relatively new concept. It's estimated to be about $48 billion a year in terms of deal flow, investment deal flow. Impact investments typically are in what's known as social enterprises, businesses that have a social purpose but are sustainable in the long run because they sell a product that consumers demand. So you can think of, for example, Ethos water that's sold at Starbucks. Ethos gives away a significant portion of its profits to fresh water projects around the world. So every time you buy an Ethos water bottle, you are supporting water access for low-income people in developing countries. Tom's shoes, every time you buy a pair of Tom's shoes, they give a pair away to a low-income family in a developing country who otherwise wouldn't have access to shoes. So these are social enterprises. Impact investors invest in these enterprises with an expectation of getting both a social return and also a financial return, because, as I mentioned, these enterprises are sustainable and do throw off cash flow, which investors can receive if they make good investments in sustainable social enterprises. These are the participants in the impact investor or social entrepreneurship marketplace, sellers, buyers, and investors. Within a health context, you can imagine hospital systems, insurance companies, and others buying better health outcomes from companies that can produce products that directly address the health needs of their target population. For example, partnering with Apple Watch to expand access to the Apple Watch Health app for low-income people who otherwise would not have access to that information as a way to address their behaviors, which again goes to that initial slide. The best way to address long-term health outcomes is to attack those larger pieces of the pie, such as behavioral decisions. So that is the second bucket. And finally, pay for success. And as I mentioned, I'm going to spend most of my time talking about this. It's relatively complex, so I look forward to your questions afterwards. I'm happy to clarify any of these points. But let me start with sort of a very basic overview of what pay for success is and how it could be used in a health context. So pay for success basically has two main ingredients. And for those of you who have heard of social impact bonds, by the way, those terms, social impact bonds and pay for success, are used interchangeably. So every time I say pay for success and you hear social impact bonds, they mean the same thing. So the two main ingredients in pay for success are, first, a performance-based contract. That performance-based contract links a producer of a health outcome in a health context, so reducing childhood obesity in a neighborhood of concentrated poverty, for example. It links that nonprofit, that for-profit, that social enterprise, whatever it is, with an end payer, with a consumer of that outcome. That end payer could be government. It typically is government, but what I'm going to propose here at this presentation is that we need private sector partners to be consumers of better health and not just government. But that consumer of the outcome signs a contract that says, if you can deliver what we care about, which is a reduction in childhood obesity, we will pay you this amount of money. We'll pay you $10,000 per child that no longer has obesity in 5 years. And we're going to base that payment based on how much we value that outcome. That value assessment could be tied to cost savings. It could be a hospital system as the end payer, who otherwise would have to pay for expensive health care for these obese children. They no longer have to make those payments, so they can use those savings to pay for that positive outcome. It could be a health insurance company. It could be a foundation. It could be a company. It could be an employer that values better health for the families of their employees. But the point is you have a contract that links that producer of the outcome with a buyer of that outcome, and there's a contract that specifies the terms by which the buyer pays for that success, and you have an independent impact auditor that will come in and determine, did you deliver the success as spelled out in the performance-based contract? And then the reason it's called pay for success is the buyer only pays for the result if it's successful. So if you fail to reduce childhood obesity in a neighborhood of concentrated poverty, as you promised to in your performance-based contract, you do not get paid. And that's a really, really important point. And it's the reason why we need bridge financing. So this is the second main ingredient in Pay for Success. And the reason we need this is because this approach flips sort of our typical model of investing in social sector work on its head. Typically, we have a problem. It could be a health problem. It could be a social problem. We put an RFP out into the social sector community, and we ask for applications, proposals to solve that problem. We select the best among them, and we fund that organization. And we say, you have 3 years to address this problem. But there's very rarely any follow-up. We don't really know if that program actually addressed the problem that we cared about. And there's very little discipline built into the system. So this flips that model on its head and says, we will only pay you if you succeed. But that creates a funding gap for that producer of the outcome, nonprofit, social enterprise, whatever, what have you. So they need working capital today. They need to run their programs for however long it takes to produce the outcome, at which point the success payment will be made, and they'll use those funds to repay the investor plus some rate of return. So that is how this particular structure is addressing those risks that we talked about earlier in the presentation. It's shifting that risk off of the end payer, off of the hospital, off of the insurance company, off of government, and onto a private sector investor. So that could be an impact investor, it could be a bank, it could be a foundation. But the point is, they're the ones bearing the risk that the program won't succeed, because if it doesn't succeed, there is no success payment, and there's no funds to repay them plus any rate of return. The financing terms of these deals vary significantly depending upon the context. These are 3 general areas that would affect those financing terms. They're relatively straightforward. How hard is it to improve a particular health metric in a particular community? What's the track record of the service provider, of the producer of that outcome? Have they been doing this for 10 years? Are they doing it for 6 months? And what's the length of the contract? Are we trying to reduce the rate of heart disease by starting in early childhood and tracking those kids until they turn 55, at which point we determine whether or not they have heart disease? That's a really long contract, and then there's going to be very little investor appetite to invest in a contract that long. So the shorter the contract, the more appetite among the investors. There is a sweet spot somewhere in the 5 to 7 year range based on previous experience. Anything longer than that, you're probably not going to get very many investors to the table. So I'm going to talk about one concrete example and walk you through how they structured it. This was an early childhood intervention. As all of you know, early childhood is critical to long-term development. And we also know that disparities as a result of poor early childhood development persist over the life course. So this is a very expensive and long-lasting consequence of not making the right types of investments far enough upstream in early childhood. So this is a Pay for Success project in Salt Lake County that was used to specifically address this challenge, increase investment in private sector investment in early childhood. The way they did this was to first identify 600 low-income kids who were very likely to otherwise need special education to remediate their learning disadvantage. They would typically show up in kindergarten so far behind that the state, in this case, and this is not specific to Utah necessarily, but the state had no other choice than to track them into special education to remediate that disadvantage. That's obviously a very expensive remediation, and it's not necessarily great for the kids who would otherwise be probably more comfortable in a mainstream classroom environment. So this project identified 600 potential kids who would fall into that category. They gave those kids a test, the Peabody Picture Vocabulary Test, to predict how many of those 600 were very likely to need special education due to that initial learning disadvantage. Those that tested 2 standard deviations below the mean, which is significant, as you know, were assigned to the Pay for Success payment group. So it was about 200, somewhere in between 200 and 300 kids of that initial 600 kid cohort. In order to provide early childhood education to all 600 kids, so it's not just provided to the kids who are very likely to need special education, it's actually provided to the whole cohort. In order to provide that that early childhood education, they needed to raise $1.1 million from a combination of Goldman Sachs and J.B. Pritzker, who's a high net worth individual. And for those of you who don't deal in finance very often, the difference between the senior loan and the subordinate loan structure is basically the senior lender gets paid back first, and if there's money left over, the subordinate lender gets paid back second. So J.B. Pritzker in this transaction was taking on more risk relative to Goldman Sachs. The United Way of Salt Lake was the project manager for this particular deal. It's known sort of in the pay for success parlance as the intermediary. And the payment terms for this project were as follows. Every year of avoided special education, beginning in kindergarten through 6th grade, every year that one of those kids in that payment group, the kids who tested 2 standard deviations below the mean, every year they avoid special education triggers a $2,500 success payment, roughly, up until the point where the initial $1.1 million investment from Goldman Sachs and J.B. Pritzker is fully repaid. At that point, the success payments drop to about half, to about $1,000 going forward, and that reflects a larger degree of the savings flowing to the state as opposed to the investor. So it costs about $2,500 a year per kid to provide special education in the state of Utah. The investors were receiving 100% of those savings up until the point where they were fully repaid, and then they basically split the savings with the state going forward. So that's why it was structured that way. So I know this is incredibly boring, but it's important, and I think illustrative of how these deals come together. As I mentioned, the first key to doing a pay for success project is identifying an end payer, somebody who values the outcome that you're striving for. In this case, the end payer was a combination of Salt Lake County and the United Way of Salt Lake. This is a little bit peculiar. It's usually just a single end payer. In this case, the state of Utah was supposed to be the end payer, but they were unable to pass the appropriation legislation. So that the County of Salt Lake and the United Way of Salt Lake stepped in at the 11th hour and said, we will pretend to be the state of Utah for 1 year to prove the concept, at which point the state of Utah better step in and take this over. And that is, in fact, exactly what happened. So going forward, the state of Utah is the end payer for this project, but for this first cohort, for this first year, the County of Salt Lake and the United Way of Salt Lake were the end payers. So once that payer is at the table willing to commit to pay for an outcome, in this case it's improvements in early childhood education, the project manager at the center of the deal is able to raise subordinate funding, investment from impact investors, foundations, others. In this case it's J.B. Pritzker. Once that subordinate capital is in place, they are able to reach out to conventional lenders like Goldman Sachs, which provided the bulk of the funds for this high-quality preschool. The combined $1.1 million was then dispersed to the high-quality preschool programs. A year goes by, an evaluator comes in, identifies how many kids avoided special education who were very likely to have otherwise needed it, absent the high-quality preschool, determines the success payments, releases those success payments back to the intermediary, who then repays the senior lender, which is Goldman Sachs, and finally, J.B. Pritzker. So this is a boilerplate pay-for-success project. They all look slightly different, but these have all of the partners that you would need if you wanted to pursue a project like this. You have your investors, private sector investors, you have your end payers, which as I mentioned, has often been a public agency, but could be a private entity, and I think it should be in many cases, particularly when it comes to health. And then you have some kind of producer of a better outcome. In this case, it's a high-quality preschool program, but in the context of health, it could be any number of programs that affect the social determinants of health. So this is very new and still unproven. There have only been 7 projects like this done in the United States, and they've been relatively limited in scope. Most have targeted prison avoidance because I think it's low-hanging fruit, to be honest. Keeping somebody out of prison is obviously very cost-effective. So any kind of intervention that reduces recidivism, for example, or keeps at-risk kids from entering the criminal justice system in the first place has the potential to save the criminal justice system a significant amount of money. So that's been an early target. Special education, again, in Salt Lake and also in Chicago. Supportive housing for the chronically homeless, and most recently, foster care avoidance for children born to homeless mothers. But this is just the tip of the iceberg. There's a lot of support out there right now to develop the pipeline of projects in the United States. There is currently a $300 million bipartisan bill in Congress that would set aside federal funds for both technical assistance, which helps develop these deals, as well as actually identifying federal agencies as end payers for success. So HHS, I know, is pursuing this, as well as other agencies within the federal government. $11 million, which was recently dispersed by the White House for technical assistance, as well as several large grants from other foundations, both in California and in Houston. So that's pay for success in a nutshell, but I didn't want, and I was asked not to focus too much on pay for success, and I think I may have failed on that count. But I want to make this larger point, which is why I was so excited to participate in this workshop and so excited to make the case for why the private sector should be playing more of a role in the social determinants. And this is a little gimmicky, which I apologize for, but I'm going to play a short video. It's a clip from 60 Minutes, and then I'm going to explain why I'm sharing this with you.
Tonight, we have some remarkable results in a daring new therapy for brain cancer. Researchers at Duke University have turned the polio virus into a predator that attacks a relentless cancer called glioblastoma. In a 10-month project for 60 Minutes, we've been following the patients in this historic experiment.
It's a hell of a thing to be told that you have months to live when you're 20 years old. In 2011, Stephanie Lipscomb was a nursing student with headaches. A doctor came in to say that she had this glioblastoma tumor, the size of a tennis ball.
I looked at the nurse that was sitting there holding my hand, and I said, I don't understand, like, what did he just say? It's kind of hard for me to process.
Stephanie became the first of 22 patients to allow a modified polio virus to be dripped directly into her brain tumor. Researchers are finding that the polio starts the killing, but it's the immune system, awakened to the infection, that wrecks the tumor. Patients like Stephanie usually have months to live, but this is her MRI last August.
And there's no cancer in this picture at all.
We don't see any cancer, active cancer cells in the tumor at all.
Dr. Henry Friedman is Deputy Director of Duke's Brain Tumor Center.
I wonder, of all the trials and all of the theories and all of the treatments that you have hoped for all of these years, how does this stack up?
This, to me, is the most promising therapy I've seen in my career, period.
Dr. Matthias Gromeyer created the virus using genetic engineering to make cancer its only target.
You have been testing this therapy against a number of other cancers just in a laboratory dish.
Yes.
What have you been able to kill so far?
So we have done this for lung cancers, breast cancers, colorectal cancers, prostate cancers, pancreatic cancers, liver cancers, renal cancers. We probably see this in just about any type of cancer you can imagine. 11
patients in the study have died, though their lives were extended. The other 11 continue to improve. Our story, Killing Cancer, will be seen this Sunday on 60 Minutes.
It's just fascinating, right? So I played this because I want to make a comparison, and that is that it's somewhat counterintuitive to use viruses to make you healthier. I think we tend to be terrified of viruses, rightly so, because they are ruthlessly efficient and effective at infecting cells and killing you. So the thought of using something that is a cause of injury to actually eliminate that injury, I think is a stumbling block for a lot of people who are not comfortable with this type of approach. I think the same challenge exists in the social sector. I think we tend to think of the private sector as something separate from our social and behavioral context, and that we should be hostile or skeptical of the private sector's ability to address the social determinants. And I guess my point with this is that just because something is scary in a certain context doesn't mean we shouldn't explore reprogramming it in some way to do good in a different context. And to me, when we talk about bringing the private sector to bear in the social determinants, that's really what we're talking about, is reprogramming business, industry to solve a problem that they've never had to solve before, and that is to address the social determinants and improve population health. I think it's possible. I'm excited about it. I think these tools provide a roadmap to accomplishing it, but that skepticism remains. So I just wanted to play that video as a means of maybe chipping away at that skepticism, just to encourage us all to think about how we can leverage the private sector more effectively to accomplish the aims that we have in health. That's my presentation. Thank you so much. My contact information is here. These are some additional resources. Thank you again.